Okay, and we are live. Hello, web shadowers. Thank you all for joining our session this afternoon. Today, we have the pleasure of hosting Dr. Mittal, who will be teaching us about obesity and lifestyle medicine. As always, please remember that the Google form for attendance will be posted in the chat box and in the description of this video at the end of the session. With that being said, you can get started whenever you're ready.
Thank you. Thank you so much for having me. It's a pleasure to be here. It's always great to be amongst people who are interested in medicine, and I'm really pleased to share my expertise and my passion in medicine, which is obesity and lifestyle medicine. So, we'll be talking a little bit about the pathophysiology of obesity, as well as going through a case and discussing management. So, let's go ahead and get started. So, when we talk about obesity, during my medical training, when I went through school, we really didn't talk about obesity in terms of it being really a chronic disease process. It was something that was maybe a side effect of different things. We talked about it in those terms, but actually, obesity is recognized as a chronic medical condition now. And that's really important to differentiate, because obviously people who are having issues with overweight and obesity, it's not as simple sometimes as eat less, move more. And we're going to talk a little bit about that in just a few slides. I'm going to start with what the traditional definition of obesity is. So that is a body mass index of greater than 30, or greater than or equal to 30. So when we talk about obesity, that doesn't really tell us the whole picture, because people of different ethnicities, as well as there might be other measurements that we should be looking at in addition to BMI. And some of those are that certain ethnicities actually have an increased risk of metabolic disease. So things like cardiovascular disease, fatty liver, diabetes, when they might not actually have an elevated BMI. So those BMI cutoffs actually need to be looked at in terms of the person in front of you and what their ethnic background is. So, for example, people from China, Japan, their definition of overweight is a BMI over 24, which in the general medical community currently, it's a BMI over 25 is considered overweight. For people of Indian origin, overweight is a BMI over 23, and obesity is a BMI over 27. And really, what this really tells us is that it's not just about weight and height, but really about where the fat distribution is. And so when we look at body fat percentage, we're getting a little bit closer to what the muscle mass and body fat composition is, which helps us to determine really what a person's risk is, more than, say, somebody who just has a lot of muscle and maybe their BMI might be in the obesity range, but that's not really the person that we're trying to identify. In my practice, I use a body composition analyzer. It's a bioimpedance scale. And basically, it sends an electric current through the body, and it breaks down into body water, muscle mass, and body fat. So for people who are men, over 25% is considered obesity, and women greater than 32%. So these are important differentiations for us to make, because again, BMI doesn't really tell the whole story. So we'll talk in a moment about waist circumference, but that is also an important measure in looking at an assessment of something called visceral fat, which is the fat that we store in the midsection around our intra-abdominal organs, our liver, our heart. And that specific type of fat is actually very inflammatory and causes issues like insulin resistance, which then in turn leads to these other metabolic diseases that we're talking about today. So let's talk about the causes, the complications, and we'll go through a case and develop a treatment plan. But let's first look at the state of our country. So in the United States, as you can see, there are about I think it was 8 or 9 states that have an obesity rate of greater than 35%. This is not taking into account overweight, right? Which is the definition of BMI over 25. But over BMI over 30, we're seeing that more than 35% of the population has obesity in the southeastern states. And as you can see, then it goes down to 30 and 35%. And there's really only, I can't even see on here which state has less than 20%. So this is concerning. It's a concerning trend. We're seeing more and more children and young adults with obesity who are developing adult onset diabetes as a consequence. So, when we look at obesity, it's really a multi system disease. And you'll see here, I have some of the common conditions outlined on the left. And then the figure on the right, you can see there's basically every body system that's being affected. So, obviously, things like prediabetes, type 2 diabetes, which used to be called adult onset diabetes, but we're seeing children with it as well, fatty liver disease, obstructive sleep apnea, cardiovascular disease, even certain cancers. So, certain cancers like liver, kidney, colon, and pancreatic are actually weight related, and postmenopausal breast cancer as well. And then, as you can see, a 5 to 10% weight loss can actually have improvements in cardiovascular and metabolic parameters. So, those are some important figures to look at for a moment if we just pause. When people are looking to seek out help for weight loss, they sometimes have these, different goals in mind about what they might want to look like or what their expectation is of what they might need to achieve to actually make an impact on their health. And really, if we take 10 and maybe even boost it up to 20% weight loss, we can really see conditions, even like diabetes, completely reversed or at least improved significantly. So, again, obesity is a complex disease. It's not as simple as calories in and calories out. And let's talk about why. So, there's a condition that we talk about in the obesity field called adiposopathy, which in loose terms means sick fat disease. What that means is the fat cells that we store our body fat in are not just inert storage. They're actually hormonally active. They're constantly releasing certain chemicals and hormones and also responding to them. When people over time have obesity or have had this progressive weight gain, and I'm going to say even in conditions that are overweight, maybe not just obesity, but that accumulation, especially of visceral fat, it leads to a hormonal dysregulation. And in that, there are a few different things. So, stomach hormones like ghrelin, which is a hunger hormone, is actually increased. So imagine if you're somebody who's overweight or has obesity and you're trying to eat less, but your hunger hormones are dysregulated in a way that actually increase your hunger. That's very difficult to deal with, and which is why it's not as easy as, well, yes, you need a calorie deficit, but how do we get there successfully? Next, fat cells themselves, as I was just mentioning, have certain hormone levels that become dysregulated. Adiponectin is a hormone that indicates satiety and fullness and has receptors in the brain, in the hypothalamus at our weight center, our weight set point. And when adiponectin levels go down, that worsens and makes it harder for people to lose weight. Leptin is a hormone that is involved in satiety. And it's not that people who have obesity have less leptin, but it's because that they become leptin resistant. In the small intestine, there are several hormones that are released in response to eating, including CCK, a hormone called GLP-1, which we will revisit in a moment, which is why I have it circled, PYY, oxyntomodulin. And these hormones have receptors in the brain and throughout the body that regulate hunger, that regulate satiety. And these can become dysregulated as well in individuals with obesity. Last, the pancreas releases many different hormones, including insulin, glucagon, pancreatic polypeptide, amylin, and these can also become dysregulated. Specifically, insulin resistance, which some of you may have heard of, is basically the underlying process of obesity and fat deposition in the muscles and the liver and the pancreas leads to a insensitivity to insulin, where you can basically imagine if we were sitting in a room and there was a lot of noise in here, I would have to speak up for you to hear me. That's what's happening when the body becomes resistant to insulin. And insulin resistance leads to, of course, the elevation in blood sugar because it can't bring it down, but also all the consequences of certain inflammatory factors, like the next thing mentioned on my slide, is that our fat cells then start releasing these inflammatory cytokines, which actually worsen the insulin resistance. And that in turn worsens the weight gain. So, as you can see, it's really not as simple as eat less, move more. So I wanted to touch a little bit on this concept for you because this was something that I had not heard of until I did my obesity medicine training. And my mind was blown when I heard about this. Our brain in the hypothalamus has a weight set point in a portion of the brain called the arcuate nucleus. And there are two different pathways you can imagine. There's the POMC-CART pathway, which when that pathway is stimulated, our body regulates hunger and satiety in order to make us lose weight, and the NPY agouti related protein pathway, which leads to weight gain. So this is very complicated. And as you can see, when the NPY pathway on the left is becoming stimulated by ghrelin, the hunger hormone, when there's perhaps less response to leptin, which tells us that we're full, we have increased hunger and in turn, we eat more. And then you can see on the other side that the opposite is happening. We're burning more calories at rest and we're decreasing our food intake when the POMC pathway is stimulated. So when we're having these leptin resistance and increased amounts of ghrelin and decreased amounts of adiponectin, that dysregulation is actually affecting our weight set point. And you've probably all of you have seen the show The Biggest Loser, right? So these people go through these intense dietary changes and exercise, and all of these things are happening. And then there's a reason why there's no reunion show, right? Weight regain is very real. And the weight set point is thought to be a big factor in that, as well as some other factors like one called metabolic adaptation, which is where when we lose weight, we need less calories to keep our body going. And that's kind of a cruel joke because now we have hormones that are telling us to eat more. They're telling us we're not as full. Our metabolism has slowed down. And this makes it even harder and harder to keep the weight off. So let's talk about our case, and we'll go through this sequentially. So you have a 45-year-old woman. She comes to your clinic. She's a mom of two, and she has a history of gestational diabetes. Her BMI is 29. Her blood pressure measurement that day is 140/95. Her waist circumference is 36 inches. She's really concerned because over the last year, she's gained 10 pounds, despite the fact that she's been trying to really make an effort to eat healthy. And she's been going to the local bar studio 2 days a week consistently for the last 6 months. And she's wondering if there's anything else that she could be doing to lose weight. So we talk about her social history and learn more about her life. She's married, she has 2 children. During the pandemic, she's been working from home and at her computer mostly, seated most of the day. She's been pretty stressed out because the kids are homeschooling, and she's been having 2 glasses of wine a night just to wind down because things have just been really hard lately. She's not a smoker. She doesn't she doesn't take any drugs. So, what are some of the key points that we want to try to take away from this right away? So, number one is okay, she's 45, she's middle aged. I always wonder, okay, is this person of childbearing age still? Are they on any kind of birth control? That's something we're going to ask her later, especially if we want to use any type of medication. That becomes important. She has a history of gestational diabetes. So we know that women who have had a history of gestational diabetes are at an increased risk of developing type 2 diabetes or prediabetes down the road. So that is definitely something that's piqued my radar. Her BMI is 29. So of course, we know that a BMI over 25 is considered overweight. We very well might even do a body composition analysis to better understand how much muscle mass and body fat she has if we have that type of machine in our office. And let's hone in on her blood pressure. So her blood pressure is elevated. This is called stage 1 hypertension. It's over 130/80. So that is something that we want to have a discussion with today, because she may not realize, even though what brought her in today was that she was wanting help to lose weight, but she has started to develop hypertension. So we look at her waist circumference, and this is something that I urge all of you when you get into your clinical rotations, really make it a habit to check waist circumference. Like we just talked, the BMI doesn't tell the whole story. So her waist circumference is over 36 inches. Now, I didn't mention to you what her ethnicity was, but let's say she was, South Asian, we'll say, because I'm South Asian origin. So a waist circumference over 31.5 inches in women of South Asian origin increases their risk for cardiovascular disease and diabetes. So definitely that's something that jumps out to me. If somebody is of Hispanic origin, African American, or Caucasian, it's 36 inches for women and it's 40 inches for men. For South Asian men and for Asian men, it's a waist circumference over 36 inches. So these are some really concerning numbers so far. So definitely we want to try to delve into a lot of different things now. But to begin with, we're going to examine her. So what types of things might we look for in an exam in a person who's coming in with high blood pressure, almost in the obesity range, history of gestational diabetes, and having some progressive weight gain? So some of the things that we're going to look for when we're examining her is her thyroid exam. So often hypothyroidism or low amounts of thyroid can be causing weight gain. So we're going to palpate her thyroid. We would also feel for any nodules. We might measure her neck size because we know that an increased neck circumference is correlated with an increased risk for obstructive sleep apnea. You might, on your history, also ask about any history of snoring. And oftentimes, obstructive sleep apnea might be discovered by me. When I screen a patient, they might complain of just daytime fatigue, feeling really sleepy and tired all the time, not waking up, feeling refreshed. It does increase the risk of high blood pressure, arrhythmias, increased obesity. So this is definitely something that you want to have your radar up for. Head and eye exam, we might look for something called scleral icterus, which is the yellowing of the eyes. That can be indicative of liver disease. I never really see that in my office, but sometimes that could be the case. Hair loss, which can be a sign of hypothyroidism or low thyroid hormone. Heart, you want to listen to the heart rhythm and the rate, especially if we discuss, prescribing any kind of medications that we use for weight management. One drug class is a amphetamine, which is a stimulant drug class. So you would want to make sure that they don't have an arrhythmia or something like that on exam, or, even if you weren't using medication, you'd want to identify that it was normal. The abdominal exam, you would look for whether their liver is palpable. So if you feel their liver, that can be indicative of an enlarged liver or fatty liver disease. Looking for their abdominal fat and their fat distribution, if they're collecting it more in their abdominal area, which we're concerned about with our patient. Striae are purple, kind of large stretch marks that are purple in color. And sometimes those can be seen in conditions where perhaps a person might be making too much cortisol hormone. So that would be something that we would look for. On the cardiovascular exam, in addition to the heart, you might look for swelling in the legs or poor vascular perfusion. If this person is someone that you might think has an increased risk of cardiovascular issues or, blockages in the arteries. And then skin darkening. So I'm going to show you a picture of what that looks like in her, because she does have darkness on the back of her neck. And this is a condition kind of going all the way around her neck called acanthosis nigricans. And this can be seen in the neck and in the underarms. And when we see this finding, it can be very concerning for insulin resistance, meaning risk for the pre-diabetes or diabetes. So on her exam today, she has the skin darkening going around, she has the increased waist circumference, but otherwise her exam is pretty normal. So, we want to try to find out more about her family history in terms of what her risks are. And these are pertinent in terms of maybe things that she might be at risk for, but also if we're going to use particular medications, we want to know. So, again, with the cardiac history, we really want to know, is there anybody who has premature heart disease? That would be men less than 50 years of age or women less than 60 years of age who may have had heart disease or a heart attack? Is there a family history of anyone with strokes, arrhythmias, or sudden cardiac death? Those, she says no. We really want to pinpoint those. Is there a family history of diabetes, thyroid disease? Oftentimes these can, yes, run in families. We might have a predetermined or a genetic predisposition, if you will. But of course, habits run in families too. So you always have to keep that in mind. Liver disease, that's an important one. Kidney disease, certain cancers. I also ask about specifically thyroid cancer because there are particular medications that we might talk about using in our patient that can potentially raise the risk of a particular type of thyroid cancer called medullary thyroid cancer. So we want to ask her all about that. And she says there's not really anything much, except for there are several family members, including her parents, who have diabetes. So in her case, we also want to ask a few other questions about her medical history. In terms of the gestational diabetes, we know that she has that. I ask about infertility because oftentimes women very at young ages might have a history of irregular periods, infertility that can be indicative of polycystic ovarian syndrome. And that is a condition that raises the risk for insulin resistance and metabolic syndrome too. Kidney stones, I ask about that in terms of particular medications that we prescribe for obesity. And there's one called topiramate that we use in conjunction with Qsymia. And that is not the case for her. Birth control, I mentioned to you before, I want to know what kind of method a woman is using for birth control. I apologize for my phone ringing there. In terms of birth control, she's on has an IUD in place. So what next? What do we do? Well, maybe we should talk about ordering some labs. So we have a really good history now. We have a good exam. I think we have a pretty good idea of what's going on, but we want to know how things are looking on the inside. So we're going to order some labs. Whoops. Let me go back to that. All right. So our labs show that she has a fasting glucose of 105. So that's of significance. A fasting glucose over 100 is concerning for prediabetes. A fasting glucose over 120, if on two different occasions you have to verify, is indicative of type 2 diabetes. So she does have signs of becoming pre-diabetic. Her hemoglobin A1C, which is a measurement of the average blood sugar over 3 months, is 5.6%. She is just on the border at 5.7 to 6.4. It's considered pre-diabetes, and then over 6.5 is type 2 diabetes. We did check her cholesterol levels as well, and that analysis showed her triglycerides were elevated to 200. Her LDL was 110. Her HDL was 46. So let's talk about these numbers for a second. So triglycerides are a form of fat in the body. When they are increased, along with a decreased HDL, which in her case is, we want it to be over 60 in women, that is concerning again for this insulin resistance. Oftentimes people might have that as a finding before anything else happens. And then her LDL, which is the quote unquote bad cholesterol, is slightly elevated over 100. Now, not everybody checks these. I do in my practice because I oftentimes am trying to identify people who have insulin resistance before they become pre-diabetic or diabetic. And so I check an insulin level. And her insulin level was 15, When we compare the insulin level to the glucose level, we can do a measurement called the HOMA-IR, which is an insulin resistance index, and it was elevated in her case. Liver and kidney function tests were thankfully normal. So when we look at the whole picture and we look at the NIH criteria for metabolic syndrome, our patient meets those criteria. So she has an increased waist circumference, her triglycerides are elevated, she has a reduced HDL cholesterol, she has increased blood pressure, and her elevated fasting blood sugar is over 100. So she's actually meeting all 5 criteria, but you just need 3 or more to be considered to have metabolic syndrome. So I'm going to shift gears for a moment and we're going to talk about what really makes up our weight and metabolic health. So there's actually so many factors, as you can see, that go into what contributes to her weight issue, but also are going to help to guide our treatment plan. So of course, nutrition is important. Probably most people know about nutrition and physical activity, right? So we'll need to address those things. Behavioral factors, so certain habits, social issues. Sometimes people are coping with food, right? In our case, our patient is having 2 glasses of wine every night. Is she self-medicating for a psychological issue like anxiety or depression? Is this just a coping mechanism in place that maybe isn't quite serving her? So we need to delve into that. Of course, there's genetic factors as well that come into play. Sleep is something that contributes to our metabolic health and weight wellness. So in terms of how much sleep, 7 to 9 hours. So there are observational data available that show us people who sleep less than 7 hours and more than 9 hours. There's an increased BMI associated with that. When we talk about physical activity, oftentimes people are thinking about the formal physical exercise, which is of course very important, but we also want to help our patients perhaps increase their organic movement. So it's called NEAT. It's non-exercise associated thermogenesis, meaning how many calories do you burn just like fidgeting and moving around? So those can be interventions like get a standing desk in our patient situation. Hormones, of course, play a role. So whether that's maybe our patient's starting to enter that perimenopausal state where we're going to start seeing that increased abdominal adiposity. Are there hormones like thyroid hormone causing a problem? And I apologize, I meant to add her thyroid hormone on the labs that we just reviewed, and her TSH was normal. Other hormones that come into play are all the ones contributing to adiposopathy that we just went over. Medications, I want to make a note of that. Our patient isn't on any medications, but I oftentimes will see people in the office who are on medications that are not weight neutral. They're actually contributing to weight gain. Some of the common ones that we'll see are things like beta blockers, which are used for blood pressure. If people are on steroids or prednisone, certain autoimmune medications and organ transplant rejection medications, antidepressants, antipsychotics. A lot of them can contribute to weight gain. And so it's a matter of identifying those and then getting with their doctors to say, hey, is there an alternative, or what else can we do here to try to help this person? Environmental factors. So things like pesticides have been linked to be obesogens. Socioeconomic, I just want to mention, not everyone has access to maybe a grocery store in their neighborhood and they're having to shop at a 7-Eleven or something like that. We have to be aware that we have to try to meet people where they are and be aware of the fact that a lot of times those socioeconomic factors do play a role in a person's decision. So let's start with the nutrition prescription. So of course, we need to talk about limiting calories. Number one, limiting processed foods. That's a big one across the bat. When people get stuck on nutrition and they talk about, well, are you doing a keto diet? Are you doing this type of diet, Mediterranean diet, DASH diet, low carb, high fat? The overall predominant commonality, if you will, for all dietary plans that are healthy is to limit processed food. So we know that processed foods are, number one, formulated to make us addicted to them. They release those pleasure centers in the brain. We often turn to them for comfort when we're stressed out because they make us feel better in the short term. So really limiting processed food, trying to limit simple carbohydrates as much as possible. So those are going to be examples like we're going to tell our patient instead of using white bread to use whole wheat bread, maybe using whole wheat pasta instead of regular pasta. How can we add more of the complex carbohydrates to her lifestyle? That's going to be the whole grains that we just mentioned, maybe foods like oats, quinoa, beans, legumes, lentils. When we talk about a healthful diet, we know that the Mediterranean diet has been shown to decrease mortality. None of the diets per se are for weight loss unless we're also creating a calorie restriction and, all the other things that we're talking about. But a healthful way of eating is going to be to limit simple carbohydrates, help our patient identify maybe hidden sources of sugar like dressings and ketchup and pre-made sauces and dressings, sauces that you might be marinating your food in, maple syrup, things like that. Sometimes certain foods get a rap as a healthy food like honey and maple syrup, but they do have sugar. So we need to limit those. We want to really get her eating real whole foods. And we want to focus on nutrient dense food. So, the reason why processed food is also really bad is it doesn't go very far, right? You could eat just a small amount of French fries or whatever, potato chips, and they're very calorically dense, but they're not nutritionally dense. So we want to try to help her eat more nutrient dense foods like what we're talking about. And then, macronutrients, I do guide my patients on, trying to get adequate amounts of protein. We typically calculate based on lean body mass so that she's getting what she needs to stay full. She's getting what she needs to maintain her muscle mass. And that might be a little bit more during a weight loss phase than maybe somebody who's just trying to eat healthy in general. So we're talking about the protein. We're talking about when we talk about fats, of course, there's different kinds of fat. We want to focus more on the mono and polyunsaturated fats. That's going to be the fats present in things like olive oil, avocado, nuts, seeds. Again, the whole foods, walnuts are a great source of omega-3, fatty fish like salmon, and really deviating away from saturated fat, which increases our patient's cholesterol. It is typically in a lot of animal-based and processed foods. So even if you're doing animal-based foods like fish and chicken, you want to veer away from red meat, which we know is a carcinogen in addition to driving cardiovascular disease. But we also want to really have a focus on what to eat. I find when I'm talking to my patients, if I, don't eat this, don't eat that, and we're only talking about the restriction, that mentally really makes a difference versus really educating her on what to eat. Meal replacements can sometimes be of help, especially when a person is transitioning to a different way of eating and they're needing some, kind of easy go-tos to lean on. Typically, we will use ones that are formulated as a meal replacement. And meal order, I wanted to just mention to you. So there are small studies that have been done looking at people who have, say, prediabetes or diabetes and how much their blood sugar increases after a meal and how much their insulin level goes up. So if a person eats their vegetables first and then their protein and then their carbohydrates on their plate, they actually have a less of an increase in their blood sugar and their insulin level. So that's a simple thing that we can tell our patient to do. Hey, eat your protein and veggies first and then eat your carbs. Fasting, I'm not going to touch on that a lot today, but I do use some fasting in my practice. And the main thing to know about fasting is that there's kind of two different ways to do it. One is called intermittent fasting. The other is called time-restricted fasting or time-restricted eating. And, in the end, it's a different way to create a calorie restriction. And there are some smaller studies in mice and in humans that indicate that perhaps eating earlier in the day can be beneficial in terms of not weight loss per se, but for how well your blood sugar is controlled. So that is something that I try to practice in my own life and I try to get my patients to, is just eat earlier in the day. Oftentimes, the eating that's happening in the evening is also kind of mindless and might be happening while we're sitting in front of the television. And next thing you know, your hand is in a bag of popcorn or chips. And then the next thing you know is it's all finished. So, eating earlier in the day, looking at the meal order, are you putting real food on your plate? And then using all of these different tools that we're talking about in conjunction is where I start. It's a lot. So next, let's talk about physical activity. So, for weight loss per se, one would have to work out about 400 minutes a week in order to lose any weight. So really, it's mostly about what we are putting into our bodies, but physical activity is really important for so many other reasons. So our patient, as you remember, has high blood pressure. She's developing insulin resistance. And just for her general health, we really want her to get moving more. So she is doing 2 days of bar, which is awesome. And so she's hitting her muscle resistance goals of 2 days a week. We also want to talk about, for general cardiovascular health benefit, 150 minutes a week of moderate intensity exercise. So that could be something like a fast walk, where moderate activity is basically where you could maybe have a conversation, but you couldn't sing a song. So that would be the intensity of moderate exercise. So you would say either 30 minutes, 5 days a week, or 75 minutes total in the week of high intensity exercise. And you got to meet your patient where they're at. So at this point, she's pretty frazzled. Things are really busy. Commend her on her 2 days a week of bar. And let's maybe just start with, let's add 1 day of a 30-minute walk, and then let's slowly increase that. We can also use her fitness tracker if she wears one to slowly increase her NEAT. So as I mentioned before, that's the activity for the calories that we burn with activities that are not formal exercise. So parking further away, taking the stairs, standing while you work, just getting more movement into your life can help to increase NEAT. And then just one note on limiting sitting. So regardless of weight loss, regardless of everything else, we know that sedentary behavior, even in people who hit their exercise goals, increases their risk for mortality. So we really want to try to limit sitting as much as possible. And then I want to just touch base with you on something called SMART goals. So when we try to tell our patient, like, okay, well, these are all the things you need to be doing, it can be really overwhelming, right? She's like, oh my God, how am I going to get 30 minutes, 5 days a week, and get to bar class and do all these dietary changes? Well, this is where we set what are called SMART goals. So that's where we're going to say that we're going to set a very specific goal. We're going to tell our patient, you are going to do 30 minutes. It's 1 day a week or 2 days a week. Let's go with 2. Measurable, it's something she can measure. It's attainable. We're not telling her to start with 5 days a week. It's relevant to her. We're going to tell her how this is going to help your insulin sensitivity. It's going to help you feel better. I'm going to bring up the fact that I think she's dealing with stress by drinking her wine every night. Exercise is going to help to reduce her stress, to help her mood. It's going to get her moving and feeling better. That's relevant to her. Also, we know that exercise can help to reduce her blood pressure, and it's time bound. So we're going to tell her, you are going to achieve this goal by 2 weeks. And then at our next visit, we're going to talk about increasing the intensity or perhaps the frequency of the goal. So moving on, we have sleep. So again, we talked a little bit briefly about obstructive sleep apnea. She didn't really have any history of snoring. Her neck size was not enlarged. Is there circadian rhythm disruption? So maybe not for her, but in general, people who work the night shift, we know that that actually increases their cardiometabolic risk. So that's something that's important to think about, and really trying to make sure that she's trying to get at least 7 hours of restorative sleep a night. Also, a note on sleep is that alcohol actually disrupts your body from going into deep sleep. So she might start sleeping better if she can cut back on her wine intake. Again, behavioral. I talk to my patients about what are other coping mechanisms to deal with stress, whether it's exercise, whether it's making time for, especially these days, it's really hard to have social interaction. Are you taking care of yourself in a way that you're not turning to food for comfort? Habits, are you sitting in front of the TV, try to eat without distractions? And then the psychological status. Oftentimes there's depression or anxiety that might need to be addressed. Medication review, I talked about with you. There's certain medications that can increase risk for weight gain. And then we need to talk about what are our options in terms of medication. So, we have 4 medications. There's one that was there before called Belviq, which was taken off the market. So now we have 4 medications that we can use for medical weight management. There's phentermine and topiramate, liraglutide, bupropion, and naltrexone. So phentermine is simply an appetite suppressant. It's a stimulant medication. We may not want to go towards that medication right now with our patient, with her blood pressure being high. But that may be something that we could consider at some point if our blood pressure was improved. Phentermine and topiramate is a brand name called Qsymia. And this medication is basically phentermine and topiramate put together. Topiramate used to be used for other indications. So especially if somebody has migraines, this is a good medication because topiramate is used for migraine prevention. And so, I might tend to use this medication in those types of people. It is contraindicated if somebody's had a kidney stone, which is why we ask about it. And it can also cause fetal malformations. So I really want to know that my patient's on a good birth control method. Liraglutide is actually remember that hormone back a few slides ago I had circled, GLP-1. So that hormone is actually found to be decreased in people with obesity. And we're still learning more about that. In people who undergo gastric bypass and gastric sleeves, they actually have an increase in GLP-1, which we think might help with the weight loss. This liraglutide is basically a GLP-1 receptor agonist, meaning it mimics that hormone that's made by our small intestine. And this medication was initially approved for type 2 diabetes under the name Victoza. And now is approved for weight management under the name Saxenda. We also have bupropion, naltrexone, which is called Contrave. Bupropion is also used in other addictions like smoking addiction. Naltrexone is used in alcohol abuse. And then we have our off-label medications like metformin, GLP-1 receptor agonists that are weekly that we actually use for diabetes, but oftentimes we can sometimes use them in people who have metabolic syndrome. So with her, a BMI over 30 or a BMI over 27 with a weight-related health complication would be an indication that we could use one of these FDA-approved medications. And her BMI was 29, and she does have a health-related condition, metabolic syndrome. So we decide to have a conversation with her, and we decide we're going to use liraglutide. So before I jump to that, I want to tell you a little bit about the lifestyle medicine. So, this is basically all the pillars that we just talked about in terms of her weight wellness plan. So again, healthful eating mostly whole plant-based food. This is from the American College of Lifestyle Medicine. These are the pillars of 6 areas to improve health: developing stress management, forming and maintaining relationships, improving sleep, and avoiding risky substances. So as you can see, we addressed all of those areas today. So we decide to prescribe liraglutide. We're going to be monitoring for contraindications. I mentioned to you earlier about medullary thyroid cancer, asking about that, and certain syndromes, like one called MEN2 syndrome. Those can run in families. It's important to recognize that this particular drug class can increase the risk for that type of cancer, at least in studies done on lab rats. So it's something I always want to make sure I don't prescribe if someone has a family history of this. We also want to look for any other contraindications, which with the liraglutide, we don't want to use it if someone has extremely high triglycerides, which is a cholesterol, or if they have history of pancreatitis. Most common side effects we're going to discuss with her today are constipation, nausea. The medication actually works by delaying stomach emptying. So people will potentially feel very nauseous if they eat a very large, heavy meal, and constipation is pretty common. We're going to set her up with an ongoing follow-up. So I want to see her in 2 weeks because I want to first see how she's doing with all the different things that we've set her goals to be, and then we'll set SMART goals at every visit Typically, I see my patients for the first 2 visits about 1 to 2 weeks apart, and then I see them every month. We do weekly health coaching in my practice. We talked about goal setting. And please always remember that the realistic changes are going to be the ones that are sustainable. Anybody can go on a crash diet. It's really not about that. It's about being able to sustain the lifestyle change. And these are my parting words in terms of advice for you future physicians is, as physicians, let us be guides for our patients by empowering them with the tools for lasting health. Thank you so much for attending, and I will now take your questions.
Thank you so, so much, Dr. Mittal. We have some questions in the Zoom chat box right now. If you want to take a look at those, I've listed some out there for you to answer.
Perfect. Sure. All right. So here we have for individuals with eating disorders, how does one go about tackling that struggle? That's a really great question. And I always screen all my patients for eating disorders. They're unfortunately very common. Binge eating disorder is the most common disorder. And then, of course, anorexia and bulimia. And really, when somebody has an eating disorder, the focus should not be about weight loss. It's really about getting them the help that they need. And typically, the first line of action is to screen them, identify it, and then refer to a mental health care provider who can help them. Therapies that have shown to be beneficial are cognitive behavioral therapy, certain medications. There is one called Vyvanse that's approved for binge eating disorder specifically, but otherwise, that really does entail a very highly specialized, eating recovery center or something like that. And if I have a patient with binge eating disorder, I really make the focus about helping them to just make healthful choices and working with a mental health care provider. So, can you manipulate the weight set point, or is it related to genes? That's a great question. We don't really know yet. Um, we do know that when people undergo gastric bypass or gastric sleeve type of surgery, their weight set point does seem to change to lower. Otherwise, we have to have an ongoing plan of action, which is all the things we talked about, plus medications often to help work against that weight set point. I'm hoping that as we learn more and more about this, I think we're learning more and more about the gut microbiome, which is the bacteria that live in our gut, and perhaps they might play a role. It's very complicated, and there could be genetic factors as well. How is it determined which pathway is most active in certain patients? So I'm assuming you might be talking about the hypothalamic pathway. If a person's on a weight gain trajectory, then I think we kind of know which pathway is being stimulated. We all know people who perhaps, eat whatever they want and they never seem to gain any weight. They might have their POMC pathway activated. How exactly does ethnicity have implications on body fat? And is it related to cultural traits like food or views on what may be considered as obese? Yeah, I think all of those play a role. So, first of all, where ethnicity plays a role is that it's about the distribution. So, again, if certain ethnicities tend to keep their weight more in their midsection and in the visceral fat abdominal area, we know that for their health, that is worse. And they can have a normal BMI, you can imagine skinny arms, skinny legs, big belly. Ethnicity does play a role in terms of that body distribution. And I'm going to call it the fat threshold. So certain ethnicities have more of a threshold for gaining weight than others before they start having metabolic consequences to them versus perhaps somebody who, might have a BMI of 35, but not have diabetes, right? So that means they had a higher threshold before they started developing at least that type of complication. Cultural traits like foods, definitely, certain cultures, we have, first of all, food across the bat is how we enjoy our cultures, how we, come together as society. And, we should be able to enjoy our culture. And I think a lot of times it's about taking the ethnic foods and really trying to figure out how to make them in a way that serve us in terms of our metabolic health and weight wellness. And again, it's not about deprivation, but if whatever the contributing factors are, whether they're a conglomeration of the Western diet, the industrialized lifestyle, the stressed out, lack of sleep, and then we're eating all these different things, something has to give. And so that's where I think that we have to come from with that. And then, yes, of course, what we consider as obesity is even changing within the medical community. And so I think raising awareness about the fact that visceral fat and where you're storing body fat really does have more consequences on the body than just total fat itself. What forms of birth control are associated with weight gain? In terms of that, there's not really any data to suggest that any particular oral contraceptives cause weight gain. Definitely, there's some weight gain associated with the Medrol shots that people receive for birth control. But typically there are other, medications, like I mentioned in my presentation, that are typically leading to weight gain. How often do you collaborate with dietitians? So yeah, I myself am doing all my own nutrition counseling. It's an area that I'm very passionate and interested in. I've done a lot of education around it, but definitely, there's a role for collaborating with dietitians. We need to have different people come together in terms of the healthcare team to really be able to help our patients with where they are and where they're trying to get to. So yes, it does happen often within the obesity and lifestyle medicine community that we collaborate with dietitians and even health coaches. Someone said, I feel like sometimes these suggestions can come off overwhelming to people. How do you go about helping those who think it's too much work and want a simple plan? So yeah, that's a great question. And again, it's about meeting people where they are. I have my patients journal, and then I'll typically give them their dietary recommendations by just modifying what they're already eating rather than starting from scratch. And I think it's really important to let our patients know that we don't expect them to get anywhere overnight. You didn't get here overnight. You're not going to change habits overnight. Sometimes the meal replacements do come in handy there to just get them started on a simple meal replacement plan while we slowly modify their foods that they're eating so that they can build those habits long term. And again, keep it simple, set small goals that build on each other. What are some common misconceptions about healthy and unhealthy? So, yeah, there's a lot of stuff out there. If you kind of scroll through Instagram or TikTok, you'll see tons of, hey, supplements, this, that. I think the biggest ones are weight loss supplements, fat burners, detox teas, which I don't even know what that means. Are they going to make you go to the bathroom? Do they have laxatives in them? So I think that, people don't want to hear this perhaps, but healthy food is real food to begin with, right? We tend to be inundated with a lot of processed foods in our lives and in advertising in the grocery store. Healthy food is real food to begin with. Again, like I mentioned, eating less saturated fat, eating more plant-based proteins, plant-based fats, and worrying about where your food comes from, thinking about that. It's didn't come from the grocery store, it came from somewhere else. So really thinking about that can be really helpful in terms of knowing whether you're eating healthy. How do you handle conversations about dieting and nutrition plans when a patient has an eating disorder? So I think I mentioned that to you. The focus really is there to get them the help that they need for their eating disorder. And then really just coming from a place of what can we do to help you be the best version of yourself. And that's going to be defined by really a more intuitive eating approach, not calorie counting, and really learning about what to put on the plate. Again, coming from a place of abundance rather than restriction. How do physicians work with meal treatment plans and nutrition with patients' ethnic foods and culture? Yep, I do that in my practice. And then how do you be culturally competent? Yeah. So, there's a lot of programs out there now that you can do as a healthcare provider if you are interested in learning more about this. There are online culinary programs, there's plant-based cooking workshops, there's chef training, there's a culinary medicine certification. Harvard has a chef culinary training, which I'm planning to do later this year. I personally have an interest, and I have a blog where I talk about how to take, say, traditional South Asian foods. My parents are from India, and really how to take those foods and make them healthier. And I'll give you an example of, an instance where I wasn't familiar with the food, but a patient that I was working with who is from Brazil. I had her explain to me what were the common kind of recipes that she was eating and what they were made of. And we took particular ingredients and substituted, and she was able to recreate her traditional dishes, but in a way that was more healthy for her. So it's definitely possible. It does take time. And I think depending on how your practice is structured, I do have the time. I've made the time for that. But if you don't, then maybe referring to a dietitian or some of these resources online to try to help them modify their foods is definitely possible. What is something you do in addressing an overweight patient to make them feel more comfortable and less insecure? Thank you for bringing that up. So, first of all, in the obesity medicine community, we're a very passionate about using patient first language. So you probably noticed throughout my presentation, I never say she's an obese person. You're not a hypertensive person. You're not a diabetic person. You're a person with obesity, a person with diabetes. So first of all, we should always come from a place of respect, no judgment. We have to be very respectful and really understand that, the goal of what I wanted to convey to you guys today was that this is very complicated, and there's no room for healthcare providers, which they do have weight bias, or anybody else to be judging anyone. It's very complicated, and it's not so simple. So we have to make them feel comfortable by also having furniture in the office that can bear their weight. We should have scales in the office that can take their weight, maybe chairs in the waiting room that are accommodated to people of all sizes. Those are just some things to begin with, and really be very non-judgmental. And even if you're not an obesity medicine care provider, coming from a place of asking for permission. She came to me today, right? In my case, to talk about this. But say you were seeing them for something else, you can ask for permission. Miss So and So, I'd like to talk to you about your weight today and some of the health consequences that might be happening. Are you open to talking about that today? And if she's not, then that's fine. You say, well, maybe we'll talk about that when you're ready. At least you've planted the seed. You've led her to believe that you're willing to have a conversation in a non-judgmental way. Could you talk about your journey to medical school and what made you want to go into this field? Yes. So my journey through medical school, I didn't really know about this field. This really all came later. In terms of, medical school, so I went to medical school at the University of Texas Health Science Center in San Antonio, and then I went on to my residency at Northwestern in Chicago. I just really decided to do internal medicine. So that was my first interest. I was always interested in the whole person and how everything works together. So that was my decision to go into internal medicine. I worked in the hospital setting initially and was really seeing the end results of a lot of these conditions. And I felt like I wanted to make an impact in the preventative side of things. How do we avoid that from happening? I was always a foodie. I was really always interested in nutrition and just a more holistic approach, I think, to health, and how can we use sleep and meditation and stress management and, all these different components really came together for me in the last 3 years. I started my practice about 3 years ago, and because I felt like there was something missing that I wanted to fill that void. And so that was my journey. What recommendations do you have for med students and residents to avoid weight gain under stress? And yes, I personally dealt with this in medical school and in residency. I used to cope by eating pecan sandies. Some of you may be familiar with those. Um, I think that you have to first be kind to yourself, understand that medical school is a very stressful time, know that residency is coming ahead and it's going to be very stressful too. So you have to really come from a place of compassion for yourself and from self-care. And so, typically weight gain is really a side effect of choices that you're making. So set those as goals. So, whether you try to like batch cook, freeze. Now we have meal delivery services like Freshly that are out there, maybe Green Chef. Try to eat more at home. Try to put together meals that are easy, And batch cook. I mean, that's a big saver for me now as a busy mom and doctor. I try to whenever I cook, I always cook double or triple so that I know we can have it as a family, at least for one other meal. And then sleep disturbances are tricky because, you're going to have all-nighters and things, especially if you're on an overnight rotation or something, but prioritize sleep and try to get it when you can. Prioritize stress management. I have my patients, we talk about stress management, like exercise, meditation, even if it's just 5 minutes of doing a calm meditation or deep breathing. You got to figure out what works for you to be in the moment, reduce stress. And typically that can be really helpful in terms of that. My blog. So on my last slide, I meant to share my social media with you. I'll put it up in a second, but it's radianthealthdallas.com. That's my practice website. I have a blog there. One's a blog and I have recipes from my kitchen. I also have a new website coming up, which will be richamittalmd.com. It's just still pending. I still need to do some finishing touches on that. So the best place to find me is that first website. There were a few more questions. With the new diet culture, how do you address the idea of health at every size? Yeah. So again, as we just talked about, somebody can have a normal BMI and not be healthy. And somebody can have an increased BMI and maybe not have as many health conditions as you might assume. So the key is don't judge people. The key is having compassion and respect no matter what size. And we can recognize that certain health conditions like the ones we talked about can occur really at any weight. But for people who have excess body fat and have obesity, things like sleep apnea, effects on the joints, things like that, we know that probably there are some health risks associated with that, even for people who are called metabolically healthy when they have obesity. But diet culture has a very judgmental, transient kind of quick fix type of feeling to it. And I think that we really need to be coming from healthy habits as a priority, and then knowing that the rest will follow. And yes, we can definitely not assume things about people's health regardless of their body size. What are your thoughts on gastric bypass? Does data show it can be something that's helpful and more complications? So yeah, I mean, I refer people to gastric bypass surgery or sleeves often. If a person has a BMI over 35 with a comorbidity, like a health complication from their weight, or a BMI over 40, typically that will trigger my mind to potentially talk about a referral. And having, again, a shared decision-making conversation with my patient is where I start. The data does show that it can help to reverse diabetes. So it's also called metabolic surgery now. And of course, long-term, there are complications potentially. People can have post-surgical complications that are more related to the anatomy. There are particular vitamin deficiencies that like iron deficiency, thiamine, things like that, that a person's going to need to know that they're going to have to be on vitamins for the rest of their life. And of course, weight regain can still happen regardless of whether a person's had surgery or not. I have patients in my practice who maybe didn't have adequate weight loss or are regaining the weight. Again, going back to that set point and that weight regain that happens. So yes, definitely there's data to show that that can be helpful. And, we just have to use all the different tools in our armamentarium to really help our patients. And again, it's about the habits and it's about partnering with them. It's about looking at overweight and obesity as medical conditions and, having less judgment and more of a comprehensive approach to how we address these things. I think that was the last question. Is that right, Sophia?
Yes, thank you so much for taking the time to answer all of those. We really, really appreciate it.
Sure. And I was
for such a wonderful presentation.
Oh, sure. Sorry. I was just going to say, I was going to share my screen at the end here. Can you see that? Or wait, maybe not.
Not yet, no.
Okay. Let me see. Well, maybe I'm not able to now. Okay, well, it was radianthealthdallas.com. And if anyone has any questions, you're welcome to email me. It's richa@radianthealthdallas.com. And I'm on Instagram and Facebook. It's at Richa Mittal MD. So be sure to, reach out if you guys have any questions. I'm always happy to mentor future doctors.
Thank you so, so much. We really appreciate it. And for all the viewers still watching, the Google form has been posted in the chat box, and it will be posted shortly in the description. And that'll be open for another 30 minutes from now. So it'll close at around 3:35 p.m. Eastern. So you have that time to verify your attendance. So thank you so much for watching. And thank you so, so much again for a wonderful presentation. Everyone learned so much.